Welcome to Infectious Laughter Podcast.
Where real, ridiculous, and relatable moments from working in healthcare are shared.
We respect HIPAA because it's real and we like our licenses. Now let's do this with culture and sensitivity. Here we go, episode 1. Let's get started with introductions.
I'm Nancy Wilson. I'm an RN. I have been for almost 30 years. Started my career back in the 1990s in Los Angeles as an AIDS hospice nurse when AIDS was all hospice, right about the time that the first protease inhibitors came out, changed the face of AIDS. We started seeing more cancers in these patients, became an oncology nurse, eventually learned telemetry, moved on to acute care or critical care. And here I am 30 years later, almost all of it at bedside.
There you go. And for our non-nursing people, oncology is cancer. And telemetry means?
Heart monitoring, monitoring of vital signs.
Gotcha. And then critical care is, your really sick patients.
Right.
Okay. Perfect.
What about you?
All right. Well, Cindy Waddell. Hello. Some people will see my name listed as Cynthia, but that's only if I'm in trouble or they forgot my name and they're just looking at the chart. So I am a younger nurse than you then. So I've been a nurse for 25 years.
Still respectable.
There you go. They're not a graduate nurse, no GN here.
Right.
But my background was biology, chemistry. I had thought about med school because, as my brother will complain to you, I never got anything lower than an A. And then decided to go into nursing due to a family friend who kept mailing me articles about nurse practitioners. So I went back to school, got my RN, and worked in the neonatal ICU for a couple years. Then went back and got my master's. And I just loved the HIV patients in the Philadelphia area when I was training. So I moved to Florida and didn't know what to do. I didn't have a lot of contacts. So I sent my resume to every infectious disease practice that was listed in my husband's medical plan. And so since then, I've been working as a nurse practitioner for about 22 years. I've worked infectious disease. I've worked a little bit of GI. I've worked skilled nursing, primary care. So here we are.
Would you say in those years you've seen and heard some funny things?
Yeah, Nancy, I think both of us have seen some interesting things.
You've seen some weird stuff.
Yeah.
Yes.
Yeah. So, which sort of leads us to doing this podcast.
Right.
Right. So I used to be a distance runner and would run with a group of people. And we would always talk about our days or our coworkers or different things. And so eventually one of the ladies I was running with, I would start talking about work and she'd go, "Oh, is it podcast time?" Because generally I would tell it with nurses' humor and then sort of answer their questions and do a little teaching. So since I've worked so much infectious disease, I liked the name Infectious Laughter.
I think it's great. I've been threatening to write a book for years of anecdotes because some of this stuff you just can't make up, we find that people who are not in healthcare and who are sick or injured, we see them at their worst days. And I've discovered that a lot of people have zero idea how the body works, and that makes for some funny situations.
For sure. And I think a lot of people try to fix things on their own, either through...
Not a good idea.
Yeah. Either through Dr. Google or cultural beliefs or their friend, or they don't want to come to the hospital, so they'll do something. And I'm always amazed at what that is. So, yeah. And making the idea for the podcast, I reached out to you because I've known you for a while. And I thought, wouldn't it be good to have two voices telling stories? As I also don't like the sound of my own voice. So I thought maybe I'll think you have another voice.
Thank you for asking me.
Yeah. Tell me, Nancy, how do you introduce yourself to patients?
I tell them, hi, I'm your nurse today. My name is Nancy. Nurse Nancy, it's easy to remember.
I will often say, hi, my name is Cindy. I'm the nurse practitioner with infectious disease. And um, you can remember my name as Cindy and not Sydney by thinking of Cindy Crawford and not Lauper because I don't have a voice that you want to listen to singing.
Mm-hmm.
Which has led to a funny moment where I said that once, and usually, families will laugh or whatever. And the next day, as I was walking by a patient room, this gentleman screamed to me out in the hallway, Cindy Crawford, I need to speak to you. And everyone looked at me, and I was like, maybe he's confused. Like,
I don't know where he got that idea.
I know, but now I've shared my secret. So, tell me, Nancy, laughter.
Oh, well, it's certainly a coping mechanism with nurses, but sometimes truly funny things happen, you know. You just don't see anywhere else. When I was a nursing student, so this would have been 1994, my first round of clinicals, I remember I was administering my first suppository.
Good times.
And I thought to myself, mid-administration, this is not like any other job I've ever had.
Right. And how am I going to explain what I did today to my friends
Right.
that are not nurses?
Right.
Yeah. Yeah. That reminds me. And I was in nursing school. I got a job as a nurse tech in the hospital. And this is back in the days of nurses, they do bed baths routinely. Things have changed a little bit, but I was told to go into this gentleman's room to do a bed bath, and I was by myself, which was fine. And I was doing my thing. So, we always go from clean to dirty. So, you can start on their arms, which are cleaner, right? And kind of work your way to more dirty areas. So as I got into the dirty zone, Nancy, I hear a little giggling in the hallway. And this man had a penile implant that was always inflated, and I had never seen such a thing in my entire life, plus my 12 years of Catholic school sheltering. So nurses can be rather funny to ourselves. And
Yes. I tell people I've seen more privates than an Army general.
oh, that's nice. I tell people I've seen more privates than in the water parks in the area.
Yes. A urologist told me once that the surgery with the highest satisfaction rate is the penile implant.
Well, I mean, you're getting what you're going for.
Right.
Right.
And it's not only the highest satisfaction with the patient, but also with their spouse. So,
if they know how to use it properly.
correct. That I was thinking about bed baths. It used to be we actually took a basin in the room, soap and water, and we gave them it was called a sponge bath.
Yeah.
In recent years, they have gotten away from that, and we use the CHG or the antiseptic wipes because they found that, I guess the studies showed that we were just washing people with dirty water.
That's absolutely true. So you have this history of, well, at least cleaner skin is better than not cleaner, and the theory of clean to dirty,
Right.
which you still do with the wipes, but they're disposable.
Right.
And it makes you wonder when they say, don't throw the baby out with the bathwater. It comes from they would draw one big tub, and dad would bathe first, and the older males in the family, and eventually mom, and then the girls, and the baby was always last.
Always last.
So,
Who probably should have been first. because little
Yeah,
babies don't have much of an immune system yet.
right. Hmm. We titled this episode Humor is a Vital Sign to Us. And I think that applies to most people in healthcare.
Mm-hmm.
And I've found over time from that very sheltered child who was shocked at my patient getting a sponge bath to now, my work humor has evolved. Did you have a similar experience or did you always kind of come off the way your humor is now?
Well, it has definitely evolved. I became a nurse a little later. I was in my 30s, late
You're
30s.
revealing your age now.
Yes. Um, so I had some life experience and I had a somewhat bawdy sense of humor, but healthcare just gave me so much more material.
Yeah, right. Fair. And I think you kind of find that you're using humor as a way to bond with your coworkers.
Yes. And I do a lot of precepting of new nurses who come in and, deer in the headlights. They're scared. They're first, they're just out of nursing school, and humor helps with that too.
Yeah, as they're doing their first suppository or
Right.
finding their first penile implant patient.
Yes.
For sure. Yeah, it makes them more comfortable.
Yes. So, and it helps with the patients too. As you know, the patient gowns are functional, but the back is open.
Mm-hmm.
And so a lot of times getting a patient up from the bed to go to the bathroom or whatever, and they kind of worry about the back being open. And so I usually say, well, that's why we call it ICU. But I'm bummed.
Done.
So I have my little lines that help, ease the tension with the patients as well.
Sure, sure. A lot of the gowns have the snaps in the shoulders.
Mm-hmm.
And I've had some patients kind of get uncomfortable because I've got to unsnap it to look at an area towards the top of their body. And especially the female patients, I'll say, look, these snap off gowns are every teenage boy's dream. So, and then they'll laugh, get a little more comfortable. Yeah.
Yeah. So humor helps, again, not only with us, but with the patients and families.
Sure. Sure. Have you ever come across an instance where you're telling a work story to non-nursing people over a meal?
Yes, I've learned not to do it over a meal, but nurses can sit down to lunch and talk about the worst of the worst. I find that there are two non-nursing types of people when you're telling stories. There are the ones who look horrified and want you to stop, but don't really say that. And then there are the ones who are like eager to hear more.
Mm. And there are the ones, say, like my husband, who's very quick to say, stop it. And he will push his food away to be, very.
You'd think we'd have gotten used to it by now.
You would think, but no, he doesn't want to hear about the pus and the blood and the bones and the,
diarrhea,
the maggots.
right?
Right.
The non-therapeutic maggots.
True.
Yeah.
Yeah. Yeah. So I am like, oh my gosh, listen to this patient. And
right. Because it's interesting to us.
It is. And it's interesting to one of my children. So then he's, getting interested and the meal is when we have time to sit down and talk.
Right.
So I have to find creative ways of saying things without saying things without shutting the whole thing down sometimes.
Do you think that child will go into healthcare?
He's thinking about it.
Oh.
He's just really good at everything. And so we'll see what he does. So I don't know. He said one time, I know you want me to be a nurse. And I said, no, I'm not telling you to be a nurse. We need more nurses, but you have to be willing to humble yourself and be willing to educate patients and deal with so many different personalities. And if that's your calling, that's your calling, but I'm not going to force that on you.
Can't handle even the thought, the sight of blood. She has passed out. But some people, it not only doesn't bother them, but they're, eager to get in there and figure things out and how the body works. And, in nursing school, in physiology, the prerequisites, you had to dissect a body of some sort. For some of us, it was a cadaver. For some, it was a cat. People are really into that. Some people, yeah, not so much.
Yeah. My lab partner, we had fetal pigs, and my lab partner was freaking out and wanted to know what the name of the fetal pig was.
Oh, that's probably not a good idea.
No. Plus, I was doing all of the work because they were not able to do so. And I literally had a scalpel and scissors in my hand, and I looked up and I said, "If you name this pig, I am leaving." So the pig was left unnamed.
As it should be.
Right. Yeah. I mean, I know we're not supposed to talk about animal stuff, but that's how you learn. You have to see it. They have to understand all the systems and the interplays. And
yeah. And I know as far as the human cadavers are concerned, these are people who have donated their, before they died, have said, donate my body to research, and were then able to go and see how the body works. And it's really fascinating.
Oh, 100%.
Yeah.
100%. I mean, I remember in nursing school too, like practicing intramuscular injections on oranges.
Right.
Because we were told the orange skin and the thickness can be very similar to a human.
I have not found that to be true.
No, because the orange holds still and it's much firmer.
You can't really pinch the skin of an orange like you do when you're giving a shot with a human.
Right.
I don't know where they got the idea for the orange. Now, we didn't do oranges, but we had this gel-like substance that, they had like on a board that was kind of cushy, to the touch.
All I'm seeing is a Jell-O mold right now in my brain.
It was kind of a Jell-O mold, but you didn't have to refrigerate it.
And you weren't going to eat it.
No, and it was flesh colored. And you could poke it multiple times, Now, before the whole HIV thing, nursing students used to poke each other and start IVs on each other, but that all changed, obviously, with the HIV epidemic.
Right, which, I imagine helped with a lot of like other infections as well that you can get from reused needles or not knowing what you're doing. And
before the HIV epidemic, nurses didn't really wear gloves. That started the whole universal precautions thing where, we wear gloves to do a lot of things that nurses never did before.
And so universal precautions would be, you wash your hands before you see a patient. You wear gloves if you're going to touch a patient, and you take the gloves off and then wash your hands again, because the gloves are a little bit of a barrier, but there's even small holes in the gloves.
Just like your skin.
100%.
But it, like you said, it is a barrier. It is a protection, a protective cover.
Right. Yeah. And we continue that to this day. And of course, you can get HIV from sexual intercourse, exchanging, basically body fluids through blood contact.
Needle stick injuries.
Sure. IV drug users. Blood transfusions in countries where they don't test the blood, which we do in the U.S., thank the Lord. Interesting. To do that in school. Yeah, we had the oranges. And thinking about it now, I mean, were they just trying to give us some confidence for when we had to do it at first? I don't know. Like, you really stuck that orange good.
And the orange didn't scream.
Fair or move.
Right.
Because
didn't flinch.
You can't approach that injection with trepidation.
Right.
You got to be confident about it. So
when
if you
you went to
do,
give them an injection?
I've had some patients who are hyper about needles, and so they were going to flinch whether I did it or not. But I never had anyone really lose it on me. What about
I did have a patient pass out once.
like mid
Uh,
injection?
yes.
Oh,
So it all worked out. I was able to finish the injection because they didn't slump over right away. But
mm.
I have found that for patients who are really nervous about, you say, okay, you do the count of three thing, but then you go on two.
Right. Not everyone does that, to be fair. So people, if you're nervous, like don't brace yourself.
Don't usually count unless they say, I'm really nervous about needles. And so then I'm like, okay, well then you can brace yourself, count of three. You do it on two. And if you're good, if you do it quick like a dart, they don't even know you did it on two.
They do not. My son recently had some vaccinations done, and I don't know if she was a medical assistant or a nurse who was doing the injections, told him with the opposite hand of, so let's say he was injecting on his right. So with his left hand to squeeze his thigh.
Mm-hmm.
And he had no idea that she did anything. And I wonder if that was.
It moves your focus.
Moves the focus. Yeah. I thought, oh,
That's a good trick.
man, I can't believe we're learning that at age 17. And he's not my first child. So, so if you ever need to try that,
Yeah.
would be an idea. Yeah. Yeah. So the other thing that popped in my head earlier when I was thinking of introducing myself, a lot of patients pre-COVID did not know what infectious disease meant, or that there were even providers who studied infectious disease, because of course we do more than HIV. So they'd look at me when I said I'm Cindy with infectious disease as if I was telling them they had Ebola or something. And I would say, infectious doesn't always mean contagious.
We keep infectious disease doctors and nurses very busy at the hospital. Anybody who comes in with sepsis or an infected wound or pneumonia, whether it's community acquired or hospital acquired, more than 50% of our patients, I would say, have an infectious disease consult.
Yeah, we're kept busy for sure, and it depends on the complexity of the patient and all of those things. But when I went in, and my only exposure pre-working in infectious disease was the HIV clinic that I attended in my training, I was shocked at actually I'm doing more antibiotics than anything else. So anyway, here we are with our nursing humor.
Yes.
Which, to be fair, oftentimes can be dark and sarcastic.
That's the best kind.
Yeah, to you and I. And of course, we never mean anything we say to be offensive.
No.
Or at someone else's expense. Sometimes it's more of our reaction to what has been said and how we handle that. But also just to tell people who we work with often, can you believe I just saw or heard this?
Right. Again, healthcare, we see and experience things that literally nobody else does. We're up close and personal with other people's bodies because, that when they come in the hospital and they're sick, that's what we're treating. And we see some strange things.
And we hear strange
things. And we have to be able to deal with that. Keeping a straight face about it in front of the patient is important. But then you want to share your experience with your fellow nurses. And yes, that's when it becomes.
You sometimes just need to let it out.
Yeah.
I had a clinical instructor in school who did not like a group of the students. Several of us were in a program where you would get your bachelor's in nursing and your master's in nursing kind of intertwined because we had had degrees in other things. And that's what I started with, but took a leave of absence because I was just burnt out between getting one degree and then working on basically two at the same time. She didn't like that. She thought every nurse practitioner should work as an RN first. And she made this very clear. So she came up to me one day and said, "You need to control your face." And I said, I'm sorry, I don't understand what you mean. And she said, "Well, I can tell you don't like me by your face." And I had to be very honest and say, "Well, I will try to control my face, but why is this coming up?" And she says, "Well, you need to control your face in front of patients and doctors and anybody else." And I said, "Well, so-and-so, I don't like you because you've made it very clear that you don't like me. But I do like my patients, even if I don't bond with them per se. And I've never had a patient complain about my face. But I'll keep that in mind, thank you." And there are times where you do have to
Yes.
check your face.
Yes. When you're doing a gigantic, complicated dressing change, when someone has a deep wound, it's probably not a good idea to say, "Ew," in front of the patient, even if that's what you're thinking. So you keep it together, you do what you need to do, and then you go out of the room and you tell all your coworkers about what you saw.
Yeah.
I mean, some wounds are more than skin deep. They go through muscle and to the bone.
Sure. And they can have all kinds of things in them.
Yes.
And smells.
Yes.
So you can't, oh, God,
Right.
Yeah.
As far as you're concerned in the room, this is all just regular business. We see this every day, which we kind of do. Some are just more than others.
And I mean, we're human at the end of the day.
Right.
So, yeah, that's true. I was just thinking of a nursing student who came once, and I like to grab nursing students if I see them not doing anything. They don't round with me per se, but they're spending clinical time with the RNs on the floor, and I said, "Hey, I'm gonna go see this really cool wound. Who wants to go in here and see him with me?" And the RN said, "Go with her." And the student looked like a chapstick, but it was some scent.
Probably mentholated.
I don't know, Nancy, but she was all up in there. And then she put 3 masks on her face.
Oh.
And I said, "I'm sorry, what are you doing?" And she says, "Well, I heard that wound smells bad." And I said, "Okay. Well, masks are not scent filtered. And you're going to need to keep it together when we're in there. And you're going to have to get used to this over time, and it's going to seem like you never can. But you will."
Yeah. Toothpaste on the inside of a mask works. Because it's got the minty scent, and that's all you smell.
Right, especially if you're not using that mask to filter.
Right. You're just,
bacteria and viruses, because that's going to break down the mask.
Right.
But if you're using it to, after COVID, I had to learn to control my face more.
Oh, because you were used to having your face completely covered, and yeah, I get that.
Yeah. I mean, we still have COVID, but after the,
right.
the beginning of it, the first few years, and then when the hospital said we could not have a mask on 24/7
right.
while at the hospital.
Well, and during the actual epidemic, when it was at its worst, we had those full face respirators and, face shields and hair bonnet. I mean, we were literally covered. We could make all sorts of faces and nobody would know.
Right. They could only just, see our eyes. And if a coworker said something, you could kind of screw up your face and kind of, as long as you controlled this section, you're okay. Yeah. So then you use it or lose it. So controlling your face is something you have to control.
That's a muscle. That's a learned behavior.
Yeah. Yeah. Well, I mean, I look forward to the stories that we'll share, and we'll provide a little education. And, we've asked other nurses and people we know, doctors and therapists and other things, we would love to hear their stories over time. So maybe we'll have a guest sometimes, or maybe we'll just, if they want us to just share their story, we'll do that too.
I hope people find this interesting and educational and maybe uplifting and funny. And I hope everybody wants to come along for the ride.
Yeah, me too. Me too. And I hope it won't create future patients, people in the community think, oh, I can't tell healthcare people things because then they'll laugh at me.
We're not laughing at them at all. We're taking a situation that maybe isn't the best and trying to cope and maybe uplift other people.
Right. And make other people more comfortable with the situation.
Like I said, we see people at their worst, their sickest. And I never make light of that.
Oh, no, never.
But the situation, I definitely can make light of.
Right. And when you've been in healthcare as long as you and I have been in, sometimes I'm amazed by a story that someone brings me.
To have done bedside almost exclusively for 30 years, apparently I do have some coping mechanisms because a lot of people burn out. And I think humor is one of the things that keeps me going.
Yeah. And having people that you can share those stories with, because if you just keep it all inside, it's not going to make it.
We'd be on a roadside somewhere.
Yeah. Yeah. Which makes me think of all kinds of stories too. So
for future episodes.
We'll get there. But it sounds like a wrap for episode 1. What do you think?
Sounds good.
All right. Cool. Well, here we go.
Okay.
All right.
The opinions expressed on this podcast are our own and do not represent our employers, hospitals, or any organization or other entities.
Any educational or health-related discussions are meant for general information and entertainment only. They are not medical advice and are not intended as a substitute for professional medical advice, diagnosis, or treatment. Always consult your own healthcare provider for any medical concerns or decisions.
While we make every effort to ensure accuracy, we make no guarantees about the completeness, reliability, or accuracy of the information presented. Medicine is always evolving and content may become outdated.
The hosts and producers of this podcast explicitly disclaim any liability or loss incurred directly or indirectly as a result of the use or application of any of the content presented.
And most importantly, we laugh with our patients and coworkers, never at them, because nursing is serious work, but it comes with seriously funny moments.
This podcast may contain discussions of medical procedures or topics that some may find sensitive. Listener discretion is advised.
I almost tripped on my way to the microphone, Nancy.
Well, that would be humorous. Unless you broke your humerus.
Ta-dunch.